in terms of the different stages and the different types of oxygen support that you can get, you start out with something called a nasal cannula. Okay, and nasal cannula provides oxygen at a very low flow. The standard therapy in terms of a prescription of oxygen is 2 liters of nasal cannula, let's say.
Dr. Kevin Chung, retired Army colonel. Congratulations on retirement from the great service of the Army. Not as great as the Air Force, but thank you so much for your service. I'm excited to chat with you tonight about some critical care medicine. How's that sound?
That sounds fantastic. Thanks for the re-invite, Dr. Gray.
I'm excited. So if you guys haven't heard, Dr. Chung was on Specialty Stories, which if you don't listen to that every week, I don't know what you're waiting on. Go sign up for that free every week as well. But you don't get cool credit and you don't get to hang out with us live. So that's the only difference. Army versus Air Force medicine. That's the first question that comes in. Air Force medicine, obviously the better medicine. So let's talk about critical care medicine. One of our favorite questions here on eShadowing is, what is bread and butter for critical care medicine?
So that's a great question. So bread and butter for critical care medicine is basically patients who come in who are in shock. I think there are many different types of shock, as you may or may not know. And what that means is that the body is gotten to the point where it can't handle whatever insult it's going through. So whether that's blood loss or response to infection, and your body shuts down. And a critical care doc, what they do is they stabilize the patient. They put IVs into the veins, sometimes large IVs that go into the central veins. And we pump up patients with fluids. Resuscitation is a big component of critical care. And then we provide support in terms of the ventilator. Sometimes it could be as simple as just providing a little mask to supplement them with oxygen. You may have heard or seen pictures of COVID patients who are hypoxemic and require higher levels of oxygen. And so in terms of the different stages and the different types of oxygen support that you can get, you start out with something called a nasal cannula. Okay, and nasal cannula provides oxygen at a very low flow. The standard therapy in terms of a prescription of oxygen is 2 liters of nasal cannula, let's say. And what that connotes is 2 liters. Every liter of oxygen is about a 3% increase in the content of oxygen, or the percentage of oxygen. If you remember from your science classes, oxygen, there's oxygen in the room. Room air has oxygen, 21% oxygen. So every liter of oxygen that you give supplemental, you go up by 3%. So 2 liters is actually about 24, 27, 28% oxygen. From there, go ahead.
Go.
No, from there, as the patient is requiring more and more oxygen support, they get, you can go up to 6 liters, sometimes 8 liters of oxygen through just the nasal cannula. And then there comes a point where the flow of the oxygen through that nasal cannula is too much, and it'll dry out your airways. So you don't want to go higher than 8 liters of oxygen. And at that point, you switch over to a simple face mask. That allows you to go up to about 15 liters of oxygen. And around then, if you do the math, 15 times 4, that's around 50, 60% if you add in room air. And then after that, that's when you're in trouble and the patient's not doing well. So as an intensivist, you're providing that kind of oxygen support. You may need to put them on a ventilator and then manage them on the ventilator. That's a whole nother topic. And then you provide hemodynamic support, which means that in a person that's in shock, their heart rate's really high, their blood pressure is really low, and so you provide medications to stabilize them, while at the same time trying to figure out what's causing the shock, because there could be 10 different things that could be going on. And you're doing this all in the first 30 minutes to an hour. So it's stabilizing a patient, especially in the emergency department, is sort of high intensity. And then you bring them to the ICU and you sort of manage the acute illness over the next few days and try to stabilize them and sort of support them as best as you can, keep them alive.
So, Dr. Chung, as you're talking, the kind of newer student into this world of picking specialties, learning about different medical specialties says, okay, you said that's critical care medicine. How is that different than emergency medicine? Because you just said that could take place in the emergency department.
Yeah. So critical care, critical care is not a place. Critical care happens anywhere. So critical care for me in the military, it can happen in the back of a plane. It can happen in the field. It can happen in an emergency department. It is a capability. So the concept that critical care only happens in an intensive care unit, I think we need to sort of debunk that. It's clear based on our experience in being able to deliver that level of care pretty much anywhere outside the ICU, that it is a capability. And so you can do critical care in the emergency department. In fact, a lot of emergency medicine doctors practice critical care. It's the initial stabilization and support of the patient. They may manage the patient for a prolonged period. Nowadays, our ICUs are so packed that you will have patients that are waiting for an ICU bed on mechanical ventilation for hours and hours and hours, sometimes days in the emergency department. So what's happening during that time? Critical care is being delivered in the emergency department. And so emergency medicine doctors, what they do is they take, let's say out of 100 patients, there may be about 10 who need, ICU acute care services. And so it is a fraction of what an emergency medicine doc does. They take care of OB emergencies, trauma emergencies. Sometimes it's a concussion or a big laceration that needs emergent sort of stabilization and hemorrhage control, and then suturing. Not all those patients need to be admitted. Maybe about 30% need to be admitted to the hospital. Of those, maybe about 20% of the people that get admitted need an ICU, hospitalization. And so that's the emergency department. Once you get into the ICU, so now you're hospitalized, you're in an environment where critical care as a capability is happening 24/7. There you have ICU nurses. There you have ICU docs. You have PharmDs. You have respiratory therapists. It's basically, teamwork to the nth degree that needs to occur to optimize care. There's physical therapists, for example. There's social workers to help with disposition. And so all those people get together, and it starts with the ICU nurse who watches the patient like a hawk. And, in an ICU setting, you don't want an ICU nurse taking care of more than 2 patients, 3 at the most. Maybe if they're not critically ill, some of them may be a step down, you can handle 3, but 2 patients per ICU nurse is really the average and the standard. When the patients get really sick, sometimes it's 1-to-1, and they're watching them like a hawk. And so a lot of times the limiting factor in terms of ICU capability is the ICU nurse.
Yeah.
And as an ICU doc, you're basically taking care of 10 of these patients on average, sometimes more, sometimes less. And you basically manage them over time, and you either manage them until they get better, or unfortunately, some of them die. So that's the kind of environment you operate in.
Yeah, we've seen some of that kind of definitions and language around the number of beds versus how many of those beds are staffed during this pandemic. I think some of the public is getting to understand that just because you have a bed doesn't mean someone can go in it. You have to have someone to staff that bed to actually take care of the patient. Unfortunately, a bed doesn't treat a patient by itself. We're not there yet. Although if you're an avid reader, what's his name? Andy Weir's new book, the guy who wrote Martian, his new book called Hail Mary. Hail Mary, yeah. How the book opens, it's basically an autonomous ICU, which is amazing.
Yeah.
So that's really cool. So
we're heading in that direction, that's for sure.
Let's talk about this training path. So it sounds like you said critical care isn't a place, and it sounds like critical care isn't a specific specialty. So how does one become you?
Yeah, that's a great question. There are many different pathways to get to the place where you're able to manage critically ill patients and become board certified in critical care. The one pathway is you can do internal medicine, and then so that training is about 3 years, internal medicine training. And then you can do pulmonary critical care, which is a 3-year fellowship, or a 2-year straight critical care fellowship. There are other pathways. So now, actually, over the last 10 years, this has been sort of booming, where you can do infectious disease and do critical care. Those people are so valued, especially over the last 18 months. If you combine ID and critical care, what have we been dealing with over the last 18 months?
Depends on what side of the aisle you're on, unfortunately.
Yeah, they are superstars right now. And so they highly coveted for their expertise. There are nephrologists, so kidney doctors, that are also critical care. There are some cardiologists who focus their practice in critical care, and then pulmonary, obviously. Or you can do straight critical care out of medicine.
Yeah.
Don't
forget the neurologists.
That's right. So another pathway is you can do a neurology residency separate from a medicine residency. So you do 4 years of neurology, just intense, just thinking about stroke, myasthenia gravis, multiple sclerosis, dealing with headaches, and then during that residency, there's a very small segment of that residency where you take care of really sick stroke patients, or traumatic brain injury, or subarachnoid hemorrhage patients. And they are cohorted in a specific ICU called the neuro ICU. And so you can do neurology and do a year or 2 of critical care fellowship and do neurocritical care. That's very, very, it's a niche specialty, but very, very exciting. And then you can do anesthesiology. So you can do a 4-year anesthesiology residency and then do an extra year of critical care. That basically gives you a year experience just devoted to all ICU, everything there is to know about ICU. And then the final 2 ways you can do this is through emergency medicine. There's a pathway where you can be an emergency medicine doc and then decide, I want to do critical care. We have many of those in the military as well as in the civilian sector. And they do 2 years of critical care fellowship, and then they mix their practice between some doing ICU shifts once in a while, and then being in the ICU for weeks, or doing ICU shifts. And then the final pathway is surgery. So surgery has a couple of pathways. You can do acute care surgery, where you do a critical care year and do a lot of acute surgery and surgical critical care on top of that, or trauma surgery, where you do your fellowship is really everything there is to do to know about trauma. You're in a trauma center and you're taking care of those really, really sick trauma patients. And so many different ways you can get into critical care. And a lot of times it's confusing because they're in a hospital. There's a medical ICU, there's a surgical ICU, there's a cardiac care unit, which is basically an ICU. There's a neuro ICU, and then there's a trauma ICU. It's endless. And so many different types of ICUs. Right now, a lot of hospitals around the country, unfortunately, they're all COVID ICUs.
Yeah. The one thing I don't think I heard, I think every specialty has a route into critical care. Pediatric intensive care, right. Neonatal intensive care, so that the pediatricians get that love as well, I'm assuming.
Yes, absolutely. So pediatrics, obviously, as a lot of people already know, is its own specialty. because I've worked with pediatricians and during my deployments, I've taken care of kids. I'm an adult doctor. Being a kid doctor or a baby doctor is 10 times harder than being an adult doctor.
Adults, aren't they?
No, maybe as an emergency medicine doc, you could say that. But for me, it's so hard because, for example, when you're doing a code. So a code is when you're doing chest compressions and patient's not doing well. For me, I don't even have to think. It's algorithmic. It's 1 amp for pretty much every drug, 1 amp of epi, 1 amp of atropine, 1 amp of bicarb, 1 amp of calcium chloride. Everything's 1 amp. And so to me, I don't even have to think. Well, unfortunately, I was in a situation where we were coding a kid, and that doesn't apply anymore. You got to take out this tape. It's called the Breslow tape. And then you got to measure the person, and then you got to, you got to look at the card, and it tells you exactly what the ACLS drugs are for that size patient.
Yeah.
It's so hard.
Have you seen the mats? So they have for codes for peds. Yeah. It's a mat that they lay out, and they just put the patient on it, so you don't have to take anything out, and it's all right on the mat, which is awesome.
I bet you an adult intensivist had a play in that, because this is too hard. There's got to be a simple way.
Yes. If this were easy, what would it look like? And it's a mat, like all of the peds bed sheets in a peds emergency department should just have that printed on there. That should be the print.
That would be so helpful.
That would be very helpful. So this student keeps asking this question: is critical care the same thing as acute care?
I think you can say that all of acute care can. A vast majority of acute care conditions can lead to critical care conditions where you have to manage them for a long time. But acute care can be an acute headache. It can be acute ankle sprain. Those conditions are not necessarily critical care conditions. And so an acute care condition may require you to go to an urgent care center and be splinted, or something like that, or given an injection to take care of your headache or something like that. That could be considered an acute care. In fact, not only urgent care, you can show up to the emergency department and have those kinds of issues resolved. And I would say that it becomes critical care when it's life-threatening or the acute condition persists and you have to be admitted to the hospital and your vital signs are at risk. And again, it's life-threatening to a certain degree. Yeah.
Interesting. Mm-hmm. Okay. Why don't we jump into some cases, and then we'll do a little Q&A at the end.
Yeah. So good. I'm going to go ahead and share a couple of slides. And, I didn't create a brand new de novo presentation just for this. I just want to show you a couple of slides, if I may, from a couple of presentations from before. Can you see this?
Yep.
Okay, so these are cases that there are two cases I want to share with you that occurred within the context of military medicine. I'm an ICU doc, but I'm also a military doc, and so I thought it'd be interesting to show over the last few years the types of cases and these are going to be the more severe cases that our military has seen, even during low op tempo periods like the last 4 or 5 years. You think you don't really hear about casualties coming from Iraq and Afghanistan and some other areas. Like the first case I'm going to talk about came from Syria. Who knew, right? I hope I'm not divulging operationally sensitive information here, but this is.
If you want to click that little hide button to get rid of that bottom little bar there where it says stop sharing.
Okay, yeah, I'll do that.
Click hide.
Yeah. So this case, actually, it's a real case that occurred in 2017. And I happened to be in San Antonio covering the ICU there. And more specifically, I was in an Ecmo ICU. Ecmo stands for extracorporeal membrane oxygenation. Many of you may have heard of that. It's basically artificial lung support, taking blood outside of the body, oxygenating it, and removing CO2 and giving it back to the patient. Well, I was basically the Ecmo attending for that week when I heard about this case. So my colleague, Dr. Gurney, who's a trauma surgeon, called me up and she's like, hey, I have this patient. This is what happened. Okay, so she's telling me the story. So this is a patient who's 18 Delta. 18 Delta stands for SF medic or SF, a special operator that he was actually an EOD expert who the patient was an EOD expert. The 18 Delta responded, but the patient was an EOD expert who was basically trying to defuse a bomb, an IED, or improvised explosive device, when the bomb exploded in front of him. And so the special ops medic, the 18 Delta, ran in and took care of the patient. The condition of the patient was such that there was an explosion right on his face. And so there was shrapnel everywhere and his neck was really bloody. After the medic took off the neck brace or the neck shield, it was just, you couldn't identify any landmarks, and there was just this massive neck wound. So it was impossible to, he needed to establish an airway. So what he ended up doing is looking for the bubbles coming out of his neck, the soft tissue in his neck, followed the bubbles and placed an ET tube into the neck. And so that's how the patient was initially managed. The patient was then transferred to a higher level of care, which in combat theater, it's a forward surgical team. So he has this ET tube in his neck, and they're bag ventilating him, and his heart, he doesn't have a pulse. And so they're doing CPR en route to the forward surgical team. And so this is a really sick patient. And so, Dr. Gurney is telling me about this patient as she's describing why she needs ECMO. They put in a central line. They do something called a resuscitative thoracotomy. Resuscitative thoracotomy, for the audience, is essentially when the heart stops in a trauma patient and you need to basically catch up. And so the trauma surgeons or the ED docs will open up the chest cavity and find the aorta and clamp the aorta below the heart so that the heart can get most of the volume and the heart can get pumping again. And so that's a resuscitative thoracotomy, and that's what they ended up doing. And the patient obviously is very sick. I'm going to just move through real quick here. With regards to the resuscitation, in this kind of setting, when the patient's losing a lot of blood, back in the day, what we used to do was component therapy, where we would get some packed red blood cells, more packed red blood cells, and then some crystalloid, either lactated ringers or normal saline, and then think about plasma. Well, over the last 20 years, we've learned that a balanced resuscitation approach in terms of blood products, balancing the red blood cells with coagulation factors that come in FFP, as well as platelets, is really the way to go. This patient ended up getting whole blood, which is really the best variety of balanced resuscitation you can give them. The patient also had a right pneumothorax, a hemopneumothorax, ended up getting a chest tube placed. They ended up doing an abdominal fast exam. So that's an ultrasound looking at the 4 different quadrants and seeing if there's fluid that was negative. And then they transported the patient, in this case, to Baghdad, where Dr. Gurney was. In this patient, in trauma patients and any patient who's in shock, we're always checking lactate. Lactate is basically a blood biomarker that tells you what level of shock somebody's in. The higher the level of shock or the more sick the patient, the higher the lactate. And so in a not so sick patient, the lactate is usually like 0.6, 0.9, less than 1. In a sick patient, you're going to have greater than 2. That's the threshold for shock. This patient had a lactate of 4, which is still not bad, but pretty bad. The patient required more resuscitation, and then in the hospital in Baghdad, that's where the Dr. Gurney was, and they were able to resuscitate the patient. Okay, so I'm gonna just go real quickly. So this is what the patient's initial chest X-ray looked like. You can see the left side is pretty whited out. You have multiple chest tubes on the left already, a chest tube on the right. The patient underwent the usual CT scan, went to the operating room for damage control surgery. This is major surgery that is usually led by either a general surgeon or a trauma surgeon in a level 1 trauma center in the United States, and then the patient was transferred for ICU care. Now, here's the thing. Here are the constellation of injuries. You can imagine when a bomb blows up in your face, you're going to get shrapnel everywhere. This guy had shrapnel to the globe, so you could see that right eye shrapnel that went directly through the eyeball, and then there's shrapnel sitting right behind the eye, the orbit, which is unfortunate. He ended up losing that eye. And then other evidence of shrapnel. And then this is what the neck looked like. You can imagine this is just the mess. I mean, soft tissue disaster with shrapnel going all the way. This is the neck, by the way, shoulders over here, and shrapnel going all the way through, decimating not only the thyroid cartilage, the hypothyroid, the trachea, but also the spine, the cervical spine, and the spinal cord. You can probably imagine, this guy ended up being a quad. And so here's the situation. This is another image of the CT scan.
Jesus.
So terrible, right? I mean, just the spinal cord. This is the spinal cord, by the way, and it should be this all the way down, and there's just bony fragments right in the middle of the spinal cord. I'm surprised this guy didn't have neurogenic shock right off the bat and died from that alone, but he didn't, fortunately. And this is what his chest X-ray looked like post-op. This is after, probably on the order of 100 units of blood. Anytime you get a ton of blood like that, there's a component of volume, but there's also a component of transfusion-related lung injury. I don't know if you've heard that term, trolley. So I would encourage you to write that down and look it up. Trolley is a common or something that you see after a transfusion. And this patient had like basically all of the above. Blast injury, volume from all the blood products, and then just developed ARDS. ARDS is acute respiratory distress syndrome. If you read about ARDS, intensivists like to categorize severity of organ injury. And the way we categorize ARDS is simple. It's mild, moderate, or severe. Or you don't have ARDS at all, right? And so the way we diagnose ARDS is you got to have bilateral, or on the chest X-ray, both left and right, diffuse infiltrates. That's one criteria. The second criteria, it's got to be acute. It can't be like over weeks this happened. That's probably pulmonary fibrosis. It's got to be acute. It's got to be within the first 24 to 48 hours. And then you got to rule out other causes like the heart. It's got to be a primary lung problem. And then we look at something called the PF ratio. PF ratio is pulmonary or PaO2, partial pressure of oxygen in the artery, divided by FiO2, and we get a ratio out of that. And so less than 300 in that ratio is mild ARDS, less than 200 is moderate ARDS, and less than 100 is severe. This patient had severe ARDS. Okay, so this is why I got called. I got called because they were ventilating him and they could not oxygenate him, okay, because of the contusions and all this other stuff, okay? And so So this is when ECMO was entertained. This is the ICU, the patient was being taken care of. And that's a ventilator right there, okay? That's a transport ventilator in a combat support hospital, not the fancy stuff that you see in sophisticated hospitals in the United States or even the world in most modern ICUs. This is a transport ventilator where maybe you can use this in a hospital setting to take the patient from a hospital bed in the ICU to CT scan. But there in the combat support hospital, you're using that ventilator. And so that was a tough situation to be in. And so on Thursday, I get the call, okay? And I say to the ECMO team that we happened to have an ECMO team available on standby, on call, 24/7. We dispatched the ECMO team Thursday night. They flew in through Germany all the way into Baghdad, Iraq. Got there that next day. They cannulated the patient, okay, like this. Put the patient on ECMO, and then transported that patient in the back of a plane on ECMO all the way back to San Antonio in one flight. Okay. What's ECMO? ECMO is basically taking a big, huge tube or cannula, putting it into a vein, okay, taking the blood out, okay, and then running that blood through an oxygenator that not only instills oxygen in the blood, but also takes away CO2. So it ventilates and oxygenates and then puts it back into the patient. You may have read or heard about in the news where COVID patients who have refractory or severe ARDS, the ones that can't be maintained on conventional mechanical ventilation, get put on ECMO. There are only so many ECMO beds in the United States. Fortunately, back then, we had many ECMO beds available. We were able to send a dedicated team to go get this service member and then put them on ECMO and bring them back. This is what that transport looked like. It's a joint operation. This is a Navy uniform. These are Air Force personnel, and you can see if you look closely, that's an Army uniform right there. So total joint operation. This is a general surgeon who wants to do, I think he may be in the cardiothoracic residency and fellowship now, but he's our main ECMO doc who is in the Navy, and a bunch of critical care nurses, RTs, critical care doc, pretty much everybody. Only in the United States do you deploy like 20 people to save one person, but in the United States we'll do that, right?
Well, that's the question I have for you is when do you ever go, the resources aren't justifiable?
Yeah. When the resources don't exist, and you're going to lead to bad outcomes in other patients if you take that resource away from their current location.
Yeah. Okay.
Yeah. I think that's when you say, sorry, we can't go. But during that time, when resources are abundant and you're talking about a 24, 25-year-old with a couple of kids, you do everything you can.
Yeah.
Yeah. So that's the situation. So I'm going to stop right there. Hold on one second and stop sharing my screen. Sorry, guys. And I'm happy to take questions.
Yeah. So a vet asks a good question that I think comes up a lot is how do you either have the genetics to keep composure in that situation or learn how to keep composure in those types of situations?
Yeah, so that's a great question. I think it's a learned behavior. I think it's our natural instinct to panic, myself included. And what you end up learning over time is that if you panic and you become paralyzed by that panic, then it does nobody any good, to include yourself. You're not helping anything. You're not helping the situation. And so I think a lot of us, whenever, this is not just in critical care, when we're dealing with a high intensity situation where we have to make decisions and function, you learn to disassociate. And so you sort of compartmentalize, okay, I know what's going on is horrible, and every decision counts, is life or death. However, I'm going to dissociate from myself from that pressure and just do my job. And this is where your training kicks in. You know, hopefully you've seen that situation over and over and over again where you know what to do every step. And that's why you do, that's why you have residency training. And that's why you have critical care and you have fellowship training. And even then, that may not be enough. I'm still learning in certain situations that I've never seen before. I mean, how many of us saw COVID patients prior to, you know, March of last year? We still have to learn. But hopefully, you know, some basics of critical care that, and you've seen, you know, conditions or situations like it, you've managed things like it, that enough times that you're not going to panic. Or even if you do panic, you're going to say, okay, I'm going to put that aside, that feeling aside, and then I'm just going to handle the situation, do my job, and then I'll deal with the panic later.
Hopefully.
You know?
Hopefully.
Yeah.
Yeah. That's where good self-care comes into play.
Right.
Let's take care of this question now. It's kind of outside of the realm of medicine. Your path to military medicine was through West Point, correct?
Correct.
So you went to military undergrad and said, I want to be a pre-med, and went into medical school after that.
That's correct.
There you go, people. So the question that a lot of people are asking, they remember C345, keep the diaphragm alive. They were looking at the CT scan going, that looks like C5. Doesn't that affect his ability to breathe on his own? How do you deal with that to go, okay, this person will likely need to be on a ventilator for the rest of his or her life. How often, if ever, does quality of life come into play when you're making these decisions?
Yeah, that's a really, really good question. And I don't know if anybody has a perfect answer to that. What I've learned over time as an intensivist is that many times, fortunately, patients declare themselves and they'll let you know when they're done. And so fortunately, the vast majority of patients, you don't really have to make a decision because the patients will tell you.
Yeah. And when you say that, they're not, just to clarify for the students, they're not literally saying, hey, extubating themselves saying, hey, doctor, I declare myself done, right? It's their body is shutting down.
Yes, the body is shutting down, multi-organ failure. There's no doubt. There's no doubt. But then there's the small percentage of patients, and I've had enough of these experiences, I'm sure you have too, where you're sure, like based on your experience, you're sure they're not going to walk again, or you're sure they're never going to wake up, or you're sure that they're going to die. And time again, I find myself being wrong. Yeah. And I've been wrong so many times. Now I refuse to play God and predict who's going to live or die.
Yeah. We are horrible at prognosis, and yet everyone wants us to do it. And I don't know why. Because,
you know, sometimes you do everything right. Every single decision that you make, you apply the best, you know, practice, medicine, evidence-based, and all the interventions, timely interventions, and all the procedures go perfectly. Patient still dies. Sometimes you do everything wrong, despite everything that you do, all the complications that have occurred, and all the mistakes that have happened to the patient, they end up surviving. It's really not up to us.
Yeah. A good question here, Dolce, I think pronounced that. And then we'll bring on some students. If you want to come on and ask some questions, let me clear everyone out of the queue. If you want to come on, ask some questions, we'll start bringing some people on. Have you ever been in a situation where you're just like, this isn't worth it? Like, it's too much stress for me. I don't know if I'm doing these people any good, because you just have a string of patients that end up not doing well. Have you ever questioned your profession at all?
That's a good question. And I think, I'll put a little twist to it, to that question, and really ask the real question. Have you ever felt burnt out?
Yeah.
Because I came into this profession and I really enjoy my job. And I told you before, I'm really biased. And so I don't think I've ever gotten to the point where I'm saying to myself, I'm going to quit. Okay. Well, I'm just going to put that aside.
Yeah.
But have I ever felt burnt out? Absolutely. Absolutely. And, when I first, I was, after I did my critical care fellowship, I landed in the burn center in San Antonio, the Army Burn Center. And in the military, there's not an ICU that's more intense than the U.S. Army Burn Center. And I landed there when, in 2005, when we were getting burn casualty after burn casualty. We were just basically getting a mini mass casualty every week. And everyone mattered. Because every patient matters anyway, but we're talking like 18-year-old, 19-year-olds, 20-year-olds that are coming in with massive burns, and their families are there, and you're like, you feel like you have to be there, and it's your mission to be there. And I certainly felt that way. And so I didn't leave the hospital much. I went home every night, but in the 3-year period, I spent pretty much every single day rounding in the ICU, including weekends. I may have had 10 days that I had off in a 3-year period, including weekends. And so I had 10 days off. Now we need 1 day off a week to feel refreshed, right? That's not enough, actually. You need at least 2. You need to get, if you work more than 80 hours a week, that's a lot. Yeah. And so 3 years of this, and towards the end, I felt myself, I think I say this all the time, but compassion is finite. It's a finite resource. And I felt myself running out of compassion. How do I know this? I became a little bit more callous. I became a little bit more testy. My interactions with my colleagues, I just wasn't myself. I was just being a jerk sometimes. I didn't want to see family members. I would purposely avoid them when I saw them in the hallway because I didn't have the emotional capacity to face them. That's when you're burned out. And hopefully you identify this way before that happens. For me, what happened to me was I got deployed. And back then, after the 3 years that I had experienced in the burn unit, the deployment was a huge break. It was a sabbatical, believe it or not. And I got deployed to the highest op-tempo, busiest, combat support hospital at that time in Iraq. It was in Baghdad. And that was still a break, a mental break, because I didn't have to think about every single patient and their families and talking to them every single day. I could take a break from that. And so what I realized from my deployment, and plus, to get personal, my family life wasn't that great. I had 3 kids, 3 babies under 5. My wife was like, where are you? Our marriage life was terrible. We were fighting all the time. And not only until I got deployed and then came back did I start realizing I need to change my ways or my family's going to disintegrate. And then I'm just not going to be able to function as a physician. So I changed everything when I came back from my deployment.
Yeah. Good. All right. Let's bring some students on and we'll ask some questions here. Make sure they're hard. Dr. Chung can handle it. Let's see if he remembers any amino acids or like the Krebs cycle.
Let me tell you a secret. No. None of that is useful.
Amy, hello.
Hi, can you hear me?
Yeah. Hi, Amy.
Hi. First of all, I wanted to say thank you so much for your honesty and sharing like your struggle and how real and how personal it was. My question that I have is, for those of us who may wear glasses or have even more severe vision impairment, what advances in technology most recently have made surgery or pursuing a career in surgery an option for us?
So for the visually impaired with very, very heavy prescription, you mean?
Right. Right.
So is that correctable to 2020 or close to it?
Well, for me personally, to tell you my situation, I'm blind in one eye, and then I get prescription correction in the other eye to 20/40.
Okay. I think there are certain certain types of surgical specialties you probably don't want to get yourself into. Microsurgery, plastics, vascular surgery. However, nowadays, it's going to be tough being able to only, have visual, a visual field from one eye. That's going to be very tough. But nowadays, even that eye that you're not able to see that well through, people to go to the operating room, people wear loupes, these goggles. And that's a pretty standard thing nowadays. And I see this, my surgical colleagues, have used loupes to go into surgery, especially when they're dealing with fine, surgery and working with vessels and in small areas. So that's one element. The second element I want to sort of highlight is telesurgery. Okay, so robotic surgery. Nowadays, you can be in one room in your office, and through robotic telesurgery, you can operate like from halfway around the globe. Now you got to work with the delay. If you nick a vessel and there's like a 0.5 second delay, that's going to be a problem. But let's just say your internet was high speed and near real time. You can pretty much operate from anywhere in a lot of surgical specialties like urology and abdominal surgery or colorectal surgery. And even like surgical oncology, it's all laparoscopic and robotic. And it takes that human element out of the equation, the shakiness, the visual challenges. And so you asked what technological advances have occurred that may help you still choose and select surgery as a profession. Robotic surgery, I gotta say.
Okay, so which, I guess kind of a follow-up real fast, so which surgeries would be like for sure not a good one to pursue, and which ones would be the better ones to lean towards?
I think like, for example, like superficial surgeries, like plastic surgeons have to do a lot with the face. You can't really do laparoscopic robotic surgery with the face. The laparoscopic robotic surgery is for like the abdominal cavity and the perineum. And so I would...
Dr. Chung, I'm going to move on. Amy, these are great questions and obviously appropriate for you. But Dr. Chung here, as a critical care doc, we'll let him stick to his specialty.
That's true.
We'll get some other people on who have questions specific to critical care.
Yeah.
Violette.
Hey guys.
Hello.
Hi.
Hi. It's great to speak with you, and thanks for coming on and talking to us.
Of course.
Thank you for your service and all you did for us and doing for us. My question to you is, here, like in emergency medicine or in a critical situation, we have a power of attorney when a patient is like just out of it.
I wish we had the power of eternity.
Yeah, me too.
So, and like when you're overseas, like in combat and something like that happens, do you call the patient's significant others and say, hey, this is what's going on. How would you like me to treat, your loved one or the patient? Or do they have like a DNR or a DNI? What do you do? Like, do you just automatically go all in and have like a 20 team? Like, I'm just very curious in that sense.
Yeah, and, I think that's a great question, because there are some terminal conditions where you do have to have end-of-life discussions. And for example, if they have a traumatic brain injury, it's catastrophic, and you got to turn off the ventilator. Now, here's the thing. There are service members that, for reasons that maybe, some will understand, I'm sure you will, and others, a lot of service members don't want to get disconnected on foreign soil. And a lot of times what will happen is they'll be on a plane and they may die in the middle of the plane. We will do chest compressions, okay, for the remainder of the flight to land them in the United States so they can die on US soil. Sometimes we will transport brain dead patients all the way back to the United States so that they can say goodbye to their families, or their families can say goodbye to them. And so we try very hard not to pronounce somebody if possible. Sometimes it's impossible. If possible, we try very hard not to pronounce somebody in theater. And this is because we're dealing with like active duty troops. These are, 19 to 40-year-olds. It's unusual to have anybody older than 40. And they're there in a foreign land trying to do their thing. And then they get hurt or injured or they develop a disease. And so as a military, our mission is to take care of them as best as we can and to bring them home.
Yeah. Wow, I just got the chills.
Mm-hmm.
All right. Thank you for that question.
Thank you. Thank you for all you do.
Mm-hmm.
Thank you so much.
All right. Janae, or how do you say that?
Janae.
Hi, Janae.
Hello. I wanted to know, like, because listening to your day-to-day and everything, it sounds very, like, heavy, like what you see from a day-to-day. Like, how do you deal with that weight on your shoulder of all the casualties and the emotions? Like, how do you deal with that outside of work?
Yeah, that's a great question. I may have told these stories, and like when you tell the stories all in succession, it may seem like that's how it is all the time. And I have to be honest with you, it's not like that all the time. It's like that in spurts. And so that's number one. And collectively, it just seems like a lot. Number two, as I said earlier, when you're dealing with tragedy, especially when like anatomically you're facing somebody that has a disfigured limb and they're just, all the things that you don't want to see as a human being, trust me, you got to learn to dissociate. And you do that naturally, to be honest with you. You do that naturally, and then you become like you go on autopilot and you handle what you need to do to take care of business. And then you try to deal with it afterwards. And so this is the trick. Afterwards, how do you deal with it? You gotta figure out a way to decompress that works for you. And everybody's a little bit different. And it's healthy. You don't want to be dysfunctionally trying to deal with these things. So spend time with your family, stay away from medicine for like an entire week, eat good foods, get plenty of sleep, exercise, go for a 5-mile run, whatever you do that can help you forget about some of the struggles whenever you're dealing with a tough situation, whether it's a combat situation or dealing with a stressful patient. You just got to learn to dissociate and then handle your emotions and figure out how to process those emotions, as you train and, ask your colleagues how to deal with it, so on and so forth. Now, very quickly, people ask me all the time and people tell me, hey, critical care must be so stressful. I don't see it that way. I don't think critical care is stressful. You know what I think is stressful? Surgery. A plastic surgeon where the expectation of the patient and the family members is perfection. And so you could do surgery on 1,000 patients, do it perfectly, and there's always going to be that one patient that has a complication. That to me is stress. Okay. Dealing with critically ill patients where they're coming in desperate and all you're doing is trying to help. You're coming from a position of just anything I do will help. Even if they're going to die, if I do this compassionately, it's still going to be help. It's not stressful.
Okay. Thank you.
Good perception there.
Yeah.
All a matter of perspective.
Yep.
Tressie. Hello, Tressie. Unmute. Unmute. All right. Rachel.
Hello.
Hi, Rachel.
Hi there.
So throughout your career, what technological advances have most profoundly impacted patient outcomes?
That's a great question. I feel like over the last 20 years, Ecmo as a technology has advanced to the point where, Ecmo wasn't invented 20 years ago, but it got refined over time. The first Ecmo patient was treated in the 70s. And the reason it wasn't adopted was because it was too clunky. There were too many moving parts. There were too many people. It took up like half the room. Not until the technology got advanced to the point where it became portable did the usage of that technology just shoot through the roof. And so I would say Ecmo has saved the most lives in critical care over the last 10 years than any other technology that I can think of, to include the ventilator. You know, the ventilator in and of itself is also a pretty remarkable technology. It helps you get through a severe illness, respiratory illness, but it can also do some damage. And when Ecmo came to be to complement the mechanical ventilator, that combination is what ended up saving, I think in my mind, a lot of lives. And so there are a lot of people alive today because of Ecmo.
Perfect. Thank you so much.
Yep.
Awesome. Thanks, Rachel. Good question. And Hope, we'll finish with a little bit of hope here, because that's what we all
Hi, Hope.
need.
Hi,
That's a great
can you
name.
hear me?
Yes.
Thank you. So I have a couple quick questions. The first is that you mentioned that there are a multitude of different training paths that you can take in order to practice critical care medicine. How often are you going between the ICU maybe to a PQ versus if you focus in pulmonary critical care that you're only focusing in that? How much flexibility is there?
That's a great question. And so I'm an adult doctor, adult intensivist. And so the different types of settings that I operate in is the medical intensive care unit, sometimes the surgical intensive care unit. I don't ever go into a PICU because I'm an adult doctor. So that's taken away. I'm not a neurosurgical or neuro critical care doctor. So I rarely go into a neuro ICU. Most of those ICUs are taken care of by neuro intensivists. And then in my practice, we're surrounded by my pulmonary colleagues. Some of my colleagues are ID critical care, others are nephrology critical care, and we all sort of cover the ICU, taking turns, like 1 week at a time in our academic practice. In my other practice, where I moonlight in a regular, civilian hospital, I just do 12-hour shifts. So I'll take, 6 12-hour shifts in a row. It's like emergency medicine. You're just doing shift work. And when I'm there for 12 straight hours. I'm physically in the ICU, but when I go home, I hand it off to somebody and somebody else covers for 12 hours. And so, a lot of ICU coverage is turning into 12-hour shifts. And so that's one aspect of it. And so you're not jumping from ICU to ICU, the different types of ICUs. Generally, what I do is I cover the ICU. If I had a full-time ICU practice, I would cover the ICU maybe 2 weeks out of the month, and that would be it. Or I would do 14 shifts out of the month, and that would be it, 12-hour shifts. And then the rest of the time, you're doing admin, you're going to the beach, you're exercising, you're spending time with your family, that kind of stuff. So talk to the version of ICU doc you want to be, and then ask them what their life is like.
Okay, will do. Thank you.
Yeah.
Is there a moment to ask about deployment requirements?
Yeah, of course.
Are there any set timeframes that when you decide you want to be an intensivist for the Army that you have to be deployed for a certain amount of time? Or is it just when the need is there, like you said, you might get deployed overseas?
Yeah, I mean, it varies based on like what the military is involved with. And so you would think that the military, all you do is go to a combat zone and help in a combat support hospital. Well, guess what? In the last 18 months, most of my colleagues have been deployed to civilian hospitals to backfill, hospitals that were becoming overwhelmed. And so they went to New York, they went on a hospital ship. They are now there in Florida in some hospitals, in Louisiana in some hospitals, covering the ICUs and just offloading the intensivists that are there. And so as an intensivist, I can tell you that the op tempo and the number of times you get deployed varies widely. You just have to be prepared. Sometimes it's just for a couple of months. Sometimes it's for 6 months. Generally, that's the longest deployment you'll have, 6 months, maybe 9. But that's pretty much it. And then you come home. 6 months is still a long time. My son did not recognize me when I got home.
Oh, wow.
Yeah.
Thank you.
Mm-hmm.
All right. Well, Dr. Chung, thank you so much for your time tonight and for your time previously on Specialty Stories. If you want more of Dr. Chung, go listen to Specialty Stories. I appreciate you. Appreciate your service. final question to finally put this to rest. Are you a USIS guy or a U-Shoes guy?
I'm a USU guy.
A USU? No, don't complicate it. Come on.
I know. We're trying to rebrand. I think USIS. See, it's so hard to say, right?
Yeah.
And then USU, I don't even know what that means. So so we've been trying to say.
I
know. So USU is what I like to say, and I'm trying to get everybody else on board with that. It's hard. It's going to take a few years for everybody to get on board. Our logo says USU, and so hopefully it'll catch on.
We can co-opt what Miami or the Ohio State calls. It's just the U. Let's just call it the U.
Yeah.
I like it. All right, everyone, have a wonderful night. Dr. Chung, again, thank you so much for coming on and sharing your wisdom.
Yeah, thanks everyone for attending. Take care.